Hello, my name is Danielle Blakely, and today I'll be discussing an urgent and growing issue in higher education, meeting the mental health needs of college students. This presentation is specifically designed for college administrators, mental health professionals, faculty, and policymakers who have the authority to influence how mental health is addressed in higher education. These groups are instrumental in shaping policy, allocating resources, and setting institutional priorities. It's important to note that while students themselves play a role in shifting mental health culture, real systematic change requires leadership buy-in. These decision makers are the ones who can champion equity-focused services, fund wellness initiatives, and create an environment where students feel emotionally safe. If we want to move from awareness to action, these are the people who must be on board. Although college is often romanticized as a time of freedom and discovery, it's also a period of overwhelming pressure. Many students face academic overload, financial instability, family expectations, and uncertainty about their future. The COVID-19 pandemic only made things worse by increasing isolation, anxiety, and depression. The numbers are startling. According to the American Psychological Association, over 60% of students now meet the criteria for at least one mental health condition, and 77% report moderate to serious psychological distress. The problem is not just the rise in need, it's that most campuses haven't adapted to meet this surge. Counseling centers are underfunded, mental health is siloed instead of integrated, and prevention often takes a backseat to crisis response. Mental health must become a foundational concern of higher education, not just a support service tucked away in one department. Why is this such a pressing issue? First, untreated mental health concerns directly affect student success, both academically and socially. Depression, anxiety, and burnout lead to lower GPAs, increased dropout rates, and a higher likelihood of substance abuse or self-harm. The human toll is immense, but there are institutional costs too. Lower retention, decreased graduation rates, and declining campus morale. Beyond that, there are serious equity concerns. Some students have access to support networks while others do not. Some feel safe asking for help. Others fear judgment, stigma, or cultural misunderstanding. Mental health is not an isolated issue. It's deeply tied to race, class, gender, and identity. If higher education continues to treat it as optional or secondary, we risk failing the very students who need support the most. The first major problem is the lack of sufficient responsive mental health services on campus. Demand is skyrocketing, but supply has kept pace. Most campuses are still operating with counselor to student ratios well above the national recommendations, some with only one provider per 1,600 students. That's like having one doctor for a small town. Students are waiting weeks for appointments or only being offered short-term therapy. In crisis situations, those delays can be devastating. Even worse, many institutions haven't modernized. Few offer telehealth, drop-in counseling, or preventative programs, and the systems they do have, like hard-to-navigate intake forms, can be overwhelming, especially for students already in distress. This isn't about increasing headcount, it's about redesigning the system so that care is accessible, visible, and culturally responsive. Mental health needs don't affect all students equally. Marginalized groups, including BIPOC, LGBTQ+, low income, first generation, and international students, face heightened stress due to systematic inequalities. These students are more likely to experience racism, homophobia, financial strain, and academic isolation. Worsley, Pennington, and Price argue that institutions must take an intersectional approach to wellness. That means recognizing how overlapping identities influence mental health and access to care. McPhee also advocate for hiring diverse staff, offering multilingual services, and adapting spaces to be inclusive and welcoming. If a counseling center only reflects dominant cultural norms, or if the intake questions don't acknowledge diverse identities, students will disengage. That's why equity must be a core principle of any mental health strategy, not an afterthought. Stigma is one of the most invisible yet powerful barriers to mental health care. Many students, especially those from cultures where mental illness is taboo, avoid seeking help or for fear of being judged. Others don't understand what counseling offers, or they think they need to be in crisis before accessing support. Mansour found that mental health literacy, teaching students about symptoms, treatment, and coping, makes a big difference. When this education is embedded early, like during orientation or in required classes, students are more likely to engage with resources. They also develop a stronger sense of resilience and self-advocacy. One-time events won't cut it. Preventative care needs to be baked into campus culture through workshops, peer mentoring, and integrated academic content. The more students see mental health wellness being discussed, the more they'll believe it matters and seek support before they hit rock bottom. First, we need to dramatically expand and diversify our mental health services. That means hiring more counselors, offering extended hours, remove session caps, and eliminating unnecessary bureaucracy. Schools should be able to adopt therapy and mobile apps, which many students prefer for privacy, flexibility, and ease of access. Equity must guide this expansion. Hiring BIPOC, multilingual, and LGBTQ+ counselors increases trust and helps students feel seen and understood. Culturally competent care is not optional. It's essential for building access. As Abrams found, schools that invest in diverse and digital services saw a 35% rise in student engagement with mental health support. Some campuses have started embedding counselors into residence halls and student unions, which reduces stigma and increases casual contact. We need more of these creative, student-centered models that meet students where they are, physically, emotionally, and culturally. Second, mental health education needs to be a part of the academic experience, not separate from it. Students benefit when wellness is addressed in their classes, advising sessions, and orientation programming. Teaching coping skills, emotional regulation, and peer support can have a lasting impact. Mansour's research found that students exposed to mental health literacy in their first semester were 25% more likely to seek help. This is cost-effective, proactive care. Faculty should be trained to recognize the stress and respond supportively. And course content can include mental health-related themes across all disciplines, from literacy to biology. Peer programs are especially impactful. When students see their peers talking about therapy or leading mental health clubs, it shifts the culture from silence to support. Third, we must broaden how we define wellness. Mental health doesn't start and end in the counseling office. It's connected to sleep, nutrition, exercise, social connection, and creative expression. Campuses should offer yoga classes, hobby nights, screen-free study spaces, and mindfulness groups as part of a holistic strategy. Research backs this up. Zhang and Fee found that students who regularly exercise reported 22% lower depression levels and higher GPAs. Similarly, leisurely reading, according to Levine, helps students reduce stress, especially when paired with unplugged spaces. The goal is to create a campus culture where self-care is supported and celebrated. Finally, no college can do this alone. Partnerships with local clinics, community organizations, and state agencies can fill resource gaps and offer continuity of care. The Ohio Department of Education supports collaborative models that share staff, data, and programming between campuses and external providers. Advocacy is also key. Colleges should push for increased mental health funding, better telehealth infrastructure, and national benchmarks for equity. According to McPhee, institutions that lead in advocacy send a powerful message. Students' well-being matters at every level. Some regions are forming mental health coalitions where campuses share resources, apply for grants, and cross-train staff. The mental health crisis in higher education is real and growing, but it's not unfixable. With proactive, inclusive, and research-driven strategies, colleges can create environments where students not only survive but thrive. Mental health is not a side issue. It's foundational to learning, belonging, and long-term success. Students deserve institutions that see their whole humanity and that invest in systems designed to support it. The steps outlined today are not just recommendations, they are a call to action.